Hi there, thank you for having me. So I'm going to talk about the English experience of a public healthcare system which has an increased number of private providers, and hopefully there'll be some lessons for Iceland. So an introduction to the English kind of national health system, they call it. It's quite similar to Iceland in that it is mostly publicly funded from central government, and most of it is provided by public hospitals and public doctors. One of the differences for the past 20 years in England, there's been an increased number of private kind of doctors and hospitals providing public services. So they're paid for by the public health system. And the other difference is in England, about half of the funding for elderly care comes from the privately paid for, and that the state doesn't provide much elderly care. It's normally other companies and other individuals that provide it. So to give you an idea of what's happened in England, around the early 90s, they started implementing a kind of market in healthcare. They wanted to change the way it was done. So at first, doctors were responsible for buying some of the healthcare services from hospitals. So this was public doctors buying services from public hospitals for their patients. Then around the late 90s, that was abolished, and instead there was these kind of regional government departments or kind of health departments set up to buy services. Now, in around the early 2000s, there was large waiting lists, and so what happened was a policy was put in place where independent companies could provide healthcare and it would be paid for by the government, but patients could go there instead, and they were called independent sector treatment centers. And as it says, the idea was to reduce waiting lists. Around 2003, this was extended upon, and there was like a national price set for operations. So every operation had a price attached to it, and patients could choose where they wanted that operation to take place, and the money would follow the patient to whoever provided it, whether it be the state hospital or it be a private hospital or a private group of doctors. This was expanded upon in 2009, where there was a change in the law, where basically they wanted to improve quality. So they said to patients, you now have a really wide choice of providers. You can choose who you want to get treated by, and that provider will be paid a national price. Then in 2012, that was expanded upon, and the law became that any healthcare service that was provided or paid for by the public sector above a certain size had to be put out for competition. So the public hospitals, private hospitals could compete to do that contract in the area, and they could compete on price as well. So they could say, we'll do it for cheaper. And so that's changing now because there's new legislation in the UK, but that's kind of where we've gone. So I think we've gone a lot further in this journey than maybe Iceland has at the moment. Now, social care, i.e. care for the elderly, is very different. Even after the Second World War, the UK government didn't really provide care for the elderly. It was left to charities and other private organizations. In the 1980s and 90s, the government wanted to encourage more investment into elderly care, so they encouraged international investors and investors to come in and build or buy up care homes. What's happened is they assumed it would reduce the cost of care, so the assumption was this would bring in more capacity and reduce cost. What's happened over time, and I'll go into this later, is international investors like private equity and real estate investors have become big players in the UK market. And so unlike in this country, it is already mostly privately provided in England. So you may wonder, well, what happened? We've had this for 20 years in the healthcare market, so what's happened? Well, as you can see, here's just one example. The number of treatment, like day treatments of patients that's been done by private kind of providers, so not by the state, it went from around 1 and a bit percent to around 6%. It's grown a lot more since then. So now private providers, private hospitals, provide over about 5 million of the treatment operations that are done, and these are paid for by the public sector. So we've kind of encouraged people to use them to reduce waiting lists. In terms of the nursing care, like elderly care, as you can see, the blue one on the screen is the government-owned care homes. So there was some that were owned by local government. As you can see over time, the number of beds that is provided by government care homes has basically reduced to nothing. The orange one is provided by the state hospital system, so a certain number of people can access elderly care from the National Health Service, but it's only if they're very serious health needs. The grey and the yellow are independent, so owned by private, they could be charities or for-profit businesses. And as you can see, most of the beds in the UK are provided by them. And the little amount that the government did provide has basically disappeared over time. And in terms of how people pay for it in elderly care in the UK, the dark blue bar is private pay, so that's where individuals pay for their own care. The light blue bar is state, and then the red one is where the state pay for things that are provided, local government pay for things that are provided by local government. So as you can see, almost half of all the money that goes into elderly care in the UK is paid for by individuals and their families. This government does not, local government does not pay for it. So I think what would be interesting for you as an audience is to know what happened after 20 years of this. What are the outcomes? So one way to look at this is what were the motivations behind this? And I think this rings true with what's been said in this room already. There was a belief that this competition would lead to better quality. There was this idea that it would increase capacity, because instead of waiting for the government to build more hospitals, they could instead rely on private companies to build them for them. They wanted to reduce waiting times, and they wanted to give patients more choice. So this was the policy aims that they put in place. So one of the arguments was about efficiency. And in a sense, there has been some efficiency, but it's kind of at what cost? It's a kind of mixed picture. So what happened was when they encouraged private companies and private hospitals to set up and provide government services, what the private hospitals did is they set up these very unusual hospitals. They are basically similar to military hospitals in the battlefield. They're very simple. And what they do is they're like a production line. They choose simple operations like hip replacements, and they just do as many as possible in a day. So it's like a production line, like in a factory. What they also do is they choose the simplest patients. So they will choose the really easy patients with little complications. They don't choose complicated patients. The state hospitals still have to deal with them. But the way pricing works in the UK, the price that's paid is meant to subsidize the cost of the easy and the hard patients. So if you only treat the easy patients, it's easier to make a profit because you don't deal with all the complications. What they also have done is they have less staff and they lower their pay. So this quote here is from a lawsuit happening at the moment in the UK. And this private hospital wants to keep providing government-funded services. And they said if you go back to the government terms and conditions, pay would increase by about 15 to 20%, because that's how much they've undercut the pay of people working in these private centres. The other aspect that you should bear in mind is that these private providers have avoided a lot of costs that the public hospitals have to pay. So they say they do it for cheaper, but that's because they avoid a lot of costs. The costs they avoid are training. All the training is still paid for by the public sector. So the public hospitals and the government pay for the doctors' training, even though they work in the private hospitals. And the safety and emergency care. If something goes wrong in a private hospital, they just take them to the public hospital and they say, you deal with it now, and it's your cost. And so, in a sense, it looks like you save money, but then if anything goes wrong, you just go back to the public system. So ultimately, how much money has been saved overall, it's quite hard to tell whether it was been worthwhile in that sense. This other idea is about capacity. We said, we'll have a lot more capacity because we have all these private hospitals now. One of the big issues in the UK is the thing that's in short supply is doctors. We don't have enough of them. Now, what happens is it's the same doctors who work in the public hospital and the private hospital. They just they move between them throughout the day and throughout the week. But the thing is, in the public hospital, the doctors see more patients in the day than the private hospital. So in a sense, we may end up in a situation where they see less patients overall, but they like working in a private hospital because they have more time and they get paid per operation. So the doctors are quite happy with it. As I said, the doctor training is still carried out by the public system, but the private hospitals benefit from that. The other thing is, because of this private capacity, the government has underinvested. They haven't built as many hospitals as they should have, because they said, but the private sector can, and we'll just pay them for it. But that's a very expensive way of building capacity. And this has become a big issue in this pandemic, because the private hospitals do not want to treat public patients. And the reason why is because there's been a backlog of insured patients. People have private insurance, and they pay more than the public sector does. So the government at the moment is asking private hospitals to help them clear a waiting list. But the private hospitals are saying, no, we don't want to, because we can get more money from insured patients. So that capacity, when we need it the most, is not available. So it's become a big issue at the moment. The other issue is conflicts of interest. In the UK, we found that over nearly 600 doctors own shares or equipment in private hospitals. And NHS hospitals, the public hospitals, are spending about 709 million kroner, 11 of them, paying private hospitals where their doctors own shares to do the work their doctors could do in the public hospital. So the doctors have a slight weird incentive. The doctors are like, I could do the work in the public hospital and get paid a fixed salary, or I can go to the private hospital and do the work and get paid for every single operation I do, and I get a share of the profit. So unsurprisingly, they like to go there and do their work. So this is one conflict of interest. The other one is overtreatment. If the doctors are paid per treatment, they are encouraged to overtreat you, and that's something that you don't normally get in a public system. And the other thing is the power of the doctors. Because the doctors are the ones in short supply, wherever they go, the money goes. Wherever they go, the public funding goes. And so they have a lot more power in the system. And there's been lots of issues around doctors just saying to public hospitals, if you don't give me better conditions, I'm going to go work somewhere else. And so this has been made worse by this. I think the other aspect is, because of this, we've turned healthcare into like a consumption good. So now this is pictures from the websites of private hospitals in the UK. They are targeting people who would use the public healthcare system, but saying, oh, you can jump the queue, you can get treatment quicker, just pay us, £190 for a scan, or here's some, pay for it like this. Now, you may think people in the UK are wealthy, but not that wealthy, so how do they afford this? Well, they offer you credit cards. They'll say, oh, we'll lend you the money. That's fine. We'll give you, we'll give you a credit card. You can spend £20,000. That's a lot of money. That's like almost a year's salary for 50% of people. And so they'll just give you the money to do it. So we're creating this kind of indebted consumer in a system where you probably wouldn't want that. Now, that's the private hospitals, or what's happened with privately provided hospitals. What about elderly care, which is a different thing? What's happened in the elderly care market is you've ended up with these kind of private equity companies, which are like international investors who invest for the short term for big rewards. They have taken over a large chunk of the market. They are the biggest providers in our market. Now, one of the things they bring with it is very complicated business structures. So this is an example of one. I can't make it bigger, but it's very complicated. This is just to provide a few care homes in the UK, and they have so many companies. And you may wonder, what are all those companies doing? That each circle is a company, by the way. I know that it looks confusing, and it is confusing. Why? You may say, why? What are they doing? So they are separating out the company that provides the care, who employs the workers and gives you the care to the elderly, from the company that owns the property. And they do this partly for tax reasons and partly because then they can move profit from a company in the UK where it's taxed to a company overseas where it's not taxed. And so a lot of it is tax avoidance, and also to protect these assets, basically to protect the property from being taken in a lawsuit. There's lots of loans between these companies, and that's also a way of extracting money, public or individuals' money, from the care system to the Cayman Islands and other offshore places where there's little tax. And as I said, they use a lot of tax havens. So one thing we did was we looked at the differences in how the big for-profit and not-for-profit companies in care spend their money. So if you give them £100, if you say 100% this is your income, where does that go in the companies? And so this is what happens. So this is the biggest 26 companies in the UK that provide care to the elderly. This is a breakdown of where they spend their revenue. So the largest cost is staff costs. So about 56%, 54%, so over half goes towards staff, which is what you'd expect. But if you look at the things highlighted in yellow, which says rent and net interest, that's like payments you make for the property and also payments for debt, for loans you have. If you look at the large for-profits, they're spending almost 11% of their money on rent and about 5%, 6% on interest on loans. And you may be like, well, why are they spending so much on that? Because that's money that could be spent on the care of the patients they have, the residents. And a lot of that money is money going to themselves. Back to that complicated diagram, this is money that's owed from one company to another, but they're all related in a giant web, like a spider's web of companies. So it's a way of shifting profit. And you may wonder, well, why do they do that in the UK? And the reason why is because they want more funding. So they often will say, well, our companies aren't making any money, so please give us more money. But actually, they're not being honest about how much money they're making, because some of it is being shifted out before it reaches that profit line. And so it's confusing our policymakers a lot. Now, this was just to break it down. This is the same as the last chart, but it's broken down the for-profits by the ones that are private equity and the ones that are not private equity to the first two columns on the left. Now, if you look at the yellow box again, if you look at rent and you look at interest paid out, the private equity ones spend about £10.83, so about 10 to 11% of all the money that you put in, if you go to a home like that, is going to debt, which is often to a related company. It's to someone they own as well, so it's just money being shifted out. And for rent, it's quite high as well, because they are shifting money out and they're not being honest about where that money is going. And that's money that could be spent on patient care. That's money that could have provided more places. So I'd say the big issue with these complicated companies is they often have a lot of debt. So they're very fragile. If things go wrong, if there's a change in the industry, if costs go up, they could easily collapse. And in England at the moment, we're at a place where the biggest 5 care home providers, the biggest 5 companies are all up for sale, but there's no buyers. They've been up for sale for a number of years, and the reason why there's no buyers is because they've taken so much money out of them that these companies are like hollow. There's nothing in them. They're like Swiss cheese. There's all these holes in them. And so the other issue is they're too big to fail. These providers, if any of them collapse, there's no one but the government to step in. So we've gone from what was an okay market, it was stable, to a market where we are at risk of having to bail out lots of care home companies. So I'll finish with this, some implications for Iceland, because it sounds like you're at the start, potentially, of a journey like this. I'd say the first question is your health system large enough to get all these efficiencies from outsourcing? I mean, we talked about the efficiencies in the UK a bit. I mean, even given the size of the population in the UK, 65 million people, so there's a lot of money spent on health. As I said, the efficiencies we thought we'd get from outsourcing healthcare haven't been that great when you put into account all the costs of training that's been missed, the cost of emergency care, and actually the fact that it's the same doctors providing care. So actually, we haven't benefited that much. Now, I don't know about Iceland. I think that's something for you to think about, but you're a smaller country, obviously. So normally these efficiencies come from big sizes, from scale. So I don't know if you would get the same benefits as the UK, and I say benefits with a caveat that we didn't really get that many benefits. I think the second thing is, what will this mean for the bargaining power of your doctors? In the UK, one thing that's happened increasingly is public hospitals have set up private patient wings. So inside the public hospital, there's a private paying part of the hospital where the doctor will go in there and earn money per treatment given. And when we asked hospitals, public hospitals, why do you do this? Is it to make lots of money? Some of them said, we don't make any money from it. So we asked them, well, why do you do it then? Because you're directing resources away from the public system in a public hospital. And they said to us, because our doctors told us to. They said, if you don't, we'll go to another hospital. And so the doctors are starting to drive the decision-making. And it's not necessarily in anyone's benefit. It benefits the doctors a lot, obviously. But not all doctors agree with this, I should say. Like, a lot of them are against what's happening, but some are benefiting a lot from it. And I would just say, I'd think about, why do the doctors want to work in the private system? Maybe they are overworked in the public system. They are in England. And maybe they're not paid enough or appreciated enough. So maybe better to focus on that. That would be better long-term strategy than these private hospitals, which create all kinds of other problems and conflicts. The next one is about regulation. I showed you that really complicated company structure, that giant web of companies. In England, we've had this care home called Southern Cross that actually collapsed a few years ago. And it scared the government because there were buyers at the time. Other companies said, we will buy out this company so you don't have to have any elderly people homeless or not without care. But the thing is, that company was so complicated that the government now has regulators who look at the finances of all these companies. But yet, even though we have so many experts in the UK, so many people who understand finance, they still can't predict when a company is going to collapse. They still can't tell what's going on. And we have a company that's in collapse at the moment, and no one saw it coming in the regulators. So I would look at this the same way as the banking crisis. you may find that some of these businesses and the way they operate is too complicated to regulate. And for a smaller country, or even for a big country like the UK, we struggle to regulate them. We struggle to understand what it means, and we struggle to understand what they're doing. So I would say if that's the case, maybe you don't want them in this country. Because in the UK, there's a whole debate now about whether we want them in the UK because it's causing damage to our country and we can't understand what they're doing. It's very complicated. And I suppose the final point is, when it comes to a healthcare system, outsourcing and privatization seems like an easy option because it's like, let's save some money by outsourcing. But I'd say, look, think about what are your priorities in your healthcare system? Who decides? If you ask doctors, they'll say, oh yeah, I want to buy this new machine and this new drug, and there's always 100 things they want to buy. And so if you let them lead the debate, they will buy lots of things. You may not want all of them. So in the UK, we've been starting to have this debate. What do we want our healthcare system to provide? Because we live in a different world from after the Second World War when we set it up. There's so many more treatments available nowadays. We may not want to fund them all. We may want to focus more on primary care, on prevention. That's where the conversation was going in the UK before COVID and the pandemic hit. So you may want to think about, is there other ways we can deliver innovation without outsourcing? Are there other ways we can spend our money wisely without overspending on things that may not be the best for our health system? So I just leave you on that, and thank you for your listening.